Hello. As told by Dr. Barrett and Dr. Maffei, I am a Wolfram patient, but I won't speak about Wolfram because the doctor already talked about it. I'm talking as a patient and as the president of the first Italian association.
Sorry, Federica. Would you turn on your camera because we don't see you? Thank you.
Okay, sorry. Okay, now can you? Okay. Yes.
Thank you. Thank you. Please go ahead.
I told. Sorry, I spoke. I speak as a patient, but also as the president of the first Italian association about Wolfram syndrome. I had the diagnosis in 2014 after years and years of trying to search something, but all the doctors told me it was all okay. And when I had the Italian diagnosis, they told me, you are the first one in Italy and there is not a cure. You can become blind, deaf, have bladder problems and die before 30 years. I didn't accept this phrase, and I created the first Facebook page about the syndrome to find other patients because I found impossible to be the first one in Italy, and also to make people aware about this disease. Then we became a real association, and we collected a lot of Italian patients from north to the south of Italy, and also in the islands. Live every day as a patient is not easy, because every day, every morning, I woke up making some plans, but everything can change in 1 minute because of the symptoms. Not all the patients have the same symptoms, but if you want to search for informations, you can write Wolfram syndrome on the internet, and there are some websites, including the Italian website about our association, Genzian. With the association, we create a conference in Italy, and we take part to conference in other countries. At the moment, we have gone in England and in France, and most important, we give support to new patients, parents, families that feel alone when they receive the diagnosis. Because when I received the diagnosis, I felt really, really lonely. So the first thing I do is giving my support to other people. Wolfram can bring to heavy consequences, and we don't have a cure yet. I fainted for choking attacks for 3 or 4 times in these years, and the consequence can be better. Yes, that's why research is important. Sorry for my English, but it's not easy to speak about Wolfram in English. And now you have to sorry me, but I'm having some bladder problems, and I have to go.
Okay.
Thank you very much. Thank you.
Thank you, Federica. Thank you for sharing your experience, and feel free to do what you said. So in the meantime, if you want to reconnect later, we stay online for you. Okay, thank you.
Okay.
Thank you, Federica. Okay, in the meantime, okay, thank you for, thank you, Tim, to stay with us, and there are some questions that are coming. So the first question is about brain MRI. The question is, do you consider MRI in each patient independently of neurological symptoms? And the point is, when you do that, you repeat as a program on a regular basis. So this is the first question.
Yeah, I think that's a really good question. At the moment, we're doing MRI scans as part of the clinical trial to see whether the treatment might slow down the brainstem atrophy. But from a clinical point of view, I would probably do it at baseline as something to follow, and then probably no more than every 5 years, because it's really useful to have as a baseline to know that everything is normal at that point, and then repeat it on a 5-yearly basis as a predictor potentially if there are symptoms that are difficult to explain. The other reason for doing it as a baseline is that we do have 1 or 2 patients who have a diagnosis of Wolfram plus something else that might be picked up. So we have one patient with white matter lesions that looks like Wolfram plus multiple sclerosis and other factors. So having that baseline to know where you start from is really helpful. But I agree, as a clinical basis, you probably don't have to do it every year, about every 5 years.
Okay, thank you. Just a comment on your answer, and this is I mean, a regular MRI, or you do any particular any protocol for that MRI?
We've been following a research protocol, but would have a protocol for an MRI that would look at the brain stem, particularly because that's where a lot of the symptoms appear to come from. So it's important to specify that you want the brain stem looked at as well.
Okay, thank you. Another question is about the mutation. If you have heterozygous mutation variants, and some lab report as a cause of mild Wolfram syndrome, what did you think about this report by geneticist lab?
Yeah, it's getting increasingly common. I think when I started 30 years ago, we only knew about the classical Wolfram syndrome pattern. As genetic testing has become more available, more and more partial forms of Wolfram are being found. And people are being found with a heterozygous mutation with just deafness, or autosomal dominant with deafness and others. I strongly recommend to get a medical genetics opinion to have a look up at the mutation that's described on the report on the databases and see if it's already been reported, because that will give a clue as to what symptoms that one might expect. So this is why it's so important to move away. We shouldn't call it Wolfram syndrome anymore, because most people with a heterozygous change don't have Wolfram syndrome in the way we described it. So we're trying to move away to say WFS1 gene spectrum disorder, because Wolfram is a very particular pattern that I've described today that's different.
Okay, thank you. So as far as I understand, you say that we have to be cautious about, I mean, some overlap clinical features that have anything to do with,
yes,
I mean, with the classical spectrum of Wolfram syndrome. Okay.
So we're being referred children with just deafness who have a heterozygous mutation that appears to be autosomal dominant, and they're not getting all diabetes or optic atrophy. So we don't call that Wolfram syndrome, we call that WFS1 gene spectrum disorder, and the outlook is different.
Okay.
Even for classic Wolfram, we have patients in the adult clinic as old as 64, 65 years of age. So there's a big variation in the condition, and it's so important for people to recognize that many patients, or some patients with Wolfram, will live well into old age in the 7th decade. And that's really important for people to remember that and know that.
Okay, thank you. We have another question about endocrine issues. Is about hypogonadism. Is this considered an hypogonadotropic or hypergonadotropic in nature. So the primary failure is in the testes or in the pituitary gland. The question is.
It's a very good question, and my colleague Dr. Renica Diaz has been doing some work collecting those up. As I recall, that there is a mixed picture. There have been reports of hypogonadotrophic hypogonadism, but the animal studies suggest there's a primary defect in the testes. There's primary abnormality, so that would be hypergonadotrophic hypogonadism. And we know that male mice and male people have reduced fertility compared to female mice and female people. So I think Dr. Diaz is on the call and may comment, but I think the primary defect is probably in the testes.
Okay, great. I have a question for you. In the meantime, yes, from the audience as well. One question is about how you organize the meeting in Birmingham. You mean, I mean the clinics. You mentioned 6 times a year. Is this correct? Just a practical question. How you have been able, to organize the clinics and have the other experts willing to work together in the 2 days? How you do that in practice? This is helpful for the other countries, including Italy or other countries in the future.
So I think it helps because we're based in a children's hospital. It's a standalone children's hospital where we're fortunate to have all the specialties under one roof. So we have the neurology team and the genetics team there, so that helps. Then we had to negotiate with the other teams to reserve 6 days in the year when they would be available for the clinic and nothing else. So we had to get some funding to do that, and our National Health Service funds 70 or 80 rare disease services, specially to deliver these sorts of clinics. And once they agree to it, we get patients to come up on that day, and in the morning they will see the eye doctor and the endocrine doctor and the neurology doctor, and in the afternoon they'll see the urology doctor or others as well. So we've sort of negotiated with specialists to come in and do that on those days. It usually works well, but the most important person is the clinic coordinator. It's the secretary, the administrator, who will arrange all the appointments on the same day to do that. And the other most important person is the family liaison officer from Wolfram Syndrome UK, who's fantastic and helps support the families when they have to travel a long way to come and visit our clinic. And that family support officer is really, really important.
Fantastic, and I'm envious of your organization. I hope that we can copy throughout Europe. There is another question about diabetes insipidus. Could you say something in short about the management of diabetes insipidus?
Yes, so in Wolfram it's almost always partial rather than complete, and the symptoms may not are complicated by either poorly controlled diabetes or a dysfunctional bladder. So therefore, it's important to look for the diagnosis accurately. And as I said, we would do a fasting urine and paired urine and plasma samples for osmolarities and sodiums to make a diagnosis. If the diagnosis is made, we would then tend to give desmopressin, usually as a spray, or more likely now as a melt or a tablet that can be taken before bed, and eventually going to 8 hourly, often that side. That the risks are overdose and then driving the sodium down too low, and we've seen that before. So we would either try and measure sodium and osmolarity every 3 months or every 6 months, or alternatively ask the family to have a day off. Out of the 7 days, 1 day they would miss a dose of desmopressin to stop it building up. So might stop it on a Sunday or something to try and prevent overdose of that.
Somebody's asking you your experience with learning disorders or autistic spectrum disorder is so frequent. How did you manage? Do you rely on specialists?
So we see it much less in Wolfram than we do in other conditions. We do see some We do see some, but we do see it less. If there is autistic spectrum disorder, first it's trying to get a diagnosis and help, and secondly, working with the school and the education services to make sure they have an education plan to support them in the school. So that's where the family liaison officer is really helpful, because we have to liaise with them and with the school to make sure they get the right provision to support them. But Wolfram is very variable. Many people with Wolfram go on to higher degrees and do very, very well. So we see less autistic spectrum.
There are so many questions. After the meeting, probably Tim will be available to chat or to write an answer. Anyway, hypothyroidism is mostly primary or pituitary? Hypothyroidism.
We see it occasionally, and it seems to be primary, and it's usually non-autoimmune. So we don't tend to see autoimmune hypothyroidism.
Okay. Yeah. Any advice on how to start insulin treatment? Is a bit different from the other the forms of diabetes in this case?
I tend to treat it as I would with a type 1 diabetes, and I would try and start them off on insulin from diagnosis if I can. Like many people, we're moving much more to insulin pumps from diagnosis than we did before, getting used, and obviously continuous glucose monitoring as well. There are some patients with partial Wolfram who will respond well to GLP-1 receptor agonists, but I would start with insulin first because it's safer to do that at the moment.
Okay. Yeah. How often you screen for sleep apnea, central apnea? How often? How frequently you screen?
So I'd only screen. I would ask sort of questions about that. So if there's a history of snoring at night or excessive tiredness in the mornings, and in those situations, I would arrange a sleep study and see if there's obstructive sleep apnea or central sleep apnea. And the other thing I would then probably do, if it's central, is I do an MRI of the brain stem and see if there's evidence of brain stem atrophy. And we do have some participants who require continuous positive airways pressure overnight as a treatment for that, but not many, thankfully, not many.
Okay. There is a general question about neurodegenerative disorders. There is any, could you say a bit more about this aspect, neurodegeneration?
So in the classic Wolfram that I described, and that's not everybody's, there's gradual loss of brain substance, so brain atrophy and brain stem atrophy. The reasons we think are apoptosis secondary to endoplasmic reticulum stress and possibly mitochondrial dysfunction as well. At that stage, it seems to be very gradual in participants, and it occurs over decades, over some time. So it is really a neuroendocrine neurodegenerative disorder that we have, and post-mortem samples have shown that brainstem atrophy as well. So that's why there's an effort really to look at treatments for neurodegeneration, because that of course underlies the optic nerve atrophy, which is the first manifestation of it, and of course the auditory nerve atrophy, which causes the high tone sensorineural deafness. But that's why we're looking at valproic acid as a neuroprotector to try and slow down that neurodegeneration.
Okay, thank you. There is a general question about the possibility to refer some patient to you in Birmingham for, I wonder, maybe general advice or refer to your clinic.
Yes, it is. Yes, it is. And I can email the contact details for that. The NHS in the UK has arrangements with other governments in Europe, such as Malta and Maltese High Commission, whereby we are able to see patients from European states who do not have a dedicated Wolfram clinic themselves. So I'm happy to forward on the contact details of our clinic, and then we would have to get the commissioners to arrange a contract to be able to see those patients. Yeah.
Thank you, Tim. I think that time is over, and most of the questions are covered now. So thank you, Tim, for your contribution, and thank you for everyone for the participation and attending this meeting. So thank you, everyone.
Thank you. Thank you.
Bye-bye. And thank you, Federica. I see you. Is everything okay now? Okay. Thank you, Federica.
Very, very
Thank
nice to
you.
see you. Very nice, Federica, and hopefully we will see you again at a meeting soon.